Assalamu alaikum. Today I will try to discuss about the adult electrolyte replacement protocol of a hospital. Oftentimes when the patients come to the hospital, their electrolytes are not in the normal range. When the physicians try to treat the patients for the conditions or diseases for which they come to the hospital, if the patient's electrolytes are not brought to the normal level quickly, then the patient will take more time to get cured, and it will also make their hospital stay longer. This is why it's very important for a hospital to have an adult electrolyte replacement protocol, which serves as a standing order for the nurse to order those electrolytes based on the patient's lab. So as I discuss about this protocol, I would like for you guys to follow with me on this protocol. So you can see this protocol is built for patients with normal renal function. So if a patient's serum creatinine is 2 milligram per deciliter or greater, then that patient will not qualify for this protocol, which will mean that the nurse will have to get patient-specific order for electrolyte replacement for that patient. This protocol for potassium, phosphate or magnesium, all of them can be replaced by oral or IV. So it depends whether the patient can take oral meds or if they cannot take the oral meds. If they cannot take the oral meds, then the nurse will have to use the IV replacement protocol. So you can see for potassium level, as it goes low, the patient's requirement for replacing the potassium also goes high. So potassium chloride can be replaced by tablet or potassium chloride packets. And if the IV replacement is needed, then the potassium chloride IV piggybacks are used. Now when the nurse check the level again, if the potassium level of the patient was in between 3.5 to 3.8, then she can check the level again in the next day morning lab. But if the potassium level was 3.1 or less, then she has to check a potassium level 4 hours after the last PO dose or 2 hours after finishing the last IV dose to make sure the patient's potassium was corrected by this replacement. Potassium chloride packets can be given in some kind of juice for easy administration to the patient. One thing to point here is potassium cannot be infused very fast. So for peripheral line, the maximum we can go is 10 mEq per hour. For central line is 20 mEq per hour. For phosphate replacement, the two things that are used is for oral phosphate replacement, nitrophos packets are used, and for IV for phosphate replacement, sodium phosphate is used. And one thing to point here is sodium phosphate IV piggybacks is normally not run very fast. They has to be run very slow. So 15 millimole IV piggyback runs over 4 hours. 21 millimole sodium phosphate runs over 4 hours. And if sodium phosphate 30 millimole is needed for the patient, that IV piggyback has to be run over 6 hours. When do the nurse check the phosphate level again? Is basically 4 hours after the PO dose or after finishing the phosphate bag. If a patient's potassium level is already high, since nitrophos already carries some potassium in it, this is why instead of nitrophos, for those patients, K-phos neutral can be used, which has less amount of potassium than nitrophos packets. And if a patient's sodium level is already high, like greater than 145 MEq per liter, then instead of sodium phosphate, potassium phosphate can be used for those patients. Now we can see that if we replace by this nitrophos or by potassium phosphate for phosphate replacement, since those carry some form of potassium in there, so the potassium replacement, if a patient is needed, that has to be taken into consideration because of giving this phosphate replacement, the patient will get some potassium, so that needs to be taken out from the potassium replacement if the patient needed for it. And if a patient sodium level is greater than 145 MEq per liter or potassium level is greater than 3.9 MEq per liter, then in both of them being very high, this protocol cannot be used. In that case, the physician has to make a decision what he or she wants to use for the patient, considering risk versus benefit. In case of magnesium replacement, magnesium oxide tablets can be used, or magnesium sulfate IV piggyBacks can be used. Again, you can see as the magnesium level goes down, the requirements for magnesium oxide tablets or magnesium sulfate IV piggyBacks also go high. And then when do the nurse again recheck the level for these two range, 1.8 to 2 or 1.5 to 1.7, he or she can check the patient's magnesium level again next morning, or if the level was very low in this range, then 4 hours after the last dose of the magnesium IV piggyBack, magnesium sulfate IV piggyBack, then the level should be checked again to make sure the patient's magnesium level was corrected. So this is how a patient's electrolytes are replaced normally by the nurses at the hospitals of America. I would like for other countries to look at it and then bring this protocol into their hospitals, because this will benefit the patients a lot and make their cure time less, and patients will feel better and get cured quickly. So this is all about today. I hope you guys will subscribe to my channel and like my videos so that it will inspire me to make more videos. That's all for today. See you next time. Thank you.